Welcome to the conversation on TYT. And, as if we needed more to be upset about COVID, there is bad news beneath the bad news. And I'm joined today by Guardian reporter Kenya Evelyn, who's going to tell us a little bit about that. And it really is how this virus is disproportionately affecting on racial lines, across racial lines. And Kenya, thanks for being on the conversation. Let's pretend nobody understands why. People in communities of color understand perfectly well why. Make us smarter on this issue, if you will. Why in a layman's way is this happening?
Simply, it's a matter of racism. I think oftentimes the conversation gets framed around race makes people disproportionately more susceptible to the COVID-19, but it's actually racism, racial disparities in the healthcare system, in many of our institutions that exacerbate existing conditions that make the coronavirus and the symptoms surrounding it unfavorable for African Americans. Where do we see that? We see that with African Americans living more disproportionately in food deserts, in supermarkets. We see that with the unequal access to healthcare, where African Americans are more likely to be uninsured than their white counterparts. Those long-standing health inequities are actually exacerbating what we see now, where African Americans are more likely to contract the virus and die from COVID-19.
When John Edwards ran for president, and this was, I'm going to go to 2004, I think he was running in a primary, and then he became John Kerry's running mate, and then he drowned in scandal, and we've never heard from him since. He did make one good point. He talked about two Americas in his primary run, how we live in two Americas. And when we saw those two Americas laid bare in Katrina, we said, we've got to learn from this, the racial disparities there. What do you think, Kenya, can be learned from COVID about this? If this is a pandemic, it's once a century, perhaps, and at least in the past century. What can we learn from this? What can we do about it?
Well, number one, we can start with unifying our systems. We can start with concentrating our systems for reporting and testing. One of the major areas that contributes to those disparities is that, number one, our testing qualifications skewed largely affluent and white. One doctor I talked to, she talked about how because of testing requirements that limited those who could qualify for the test to travel, those who had recent travel to susceptible zones, that limited and essentially blocked a lot of African Americans, primarily from areas we see such as Queens or Brooklyn, from qualifying for a test or even being allowed to seek testing or seek qualifications for testing compared to their more affluent counterparts in places like Manhattan. That allowed certain communities to experience the virus spreading for weeks before we even confirmed our first case. As we know, the first case was actually 2 weeks prior, at least what we know of. A Latina woman in California was likely our first case in early February, before what we knew 2 weeks later in Washington state. That's because Black Americans and as well as Brown and Native Americans are less likely to be able to qualify for those tests, even though they're more likely to live in environments that make it conducive to contracting the virus. They live in urban areas. They're more likely to travel long distances due to gentrification, pushing them out of these communities. So because African Americans are more likely to live in areas that are heavily concentrated in urban communities, because they're more likely to take public transportation, this made them more susceptible to contracting the virus, even though many of our early testing requirements skewed heavily affluent and white, requiring foreign travel, requiring specifically travel to coronavirus areas that had already experienced their first case. And because of this allowed the virus to permeate around the Black and Brown communities for quite some time, in communities where they could not access quality healthcare because of closed hospitals, because of lack of cuts to Medicare and Medicaid. Those are longstanding societal and healthcare issues that contribute to why we are seeing African Americans disproportionately contracting the virus now. And what the CDC even tells us is that up to 50% of cases aren't even reflecting those racial or ethnic disparities. So they could be quite worse. What we see here is that there needs to be some type of nationalized consistency in how people are reporting their data sets, and requirements that every state is reporting who contracts the virus, how they contracted the virus, how they recovered, and other various points that could factor into how we target certain communities for testing and treatment.
There's something else here, and I'm asking about general wellness, right? I mean, because you see the parts of the demographics of those affected by corona, and while they do skew on race, they skew on race as well because of pre-existing conditions. So is this a clarion call for general wellness? I mean, I think that you intimated that when you first responded, but in terms of high blood pressure, in terms of obesity, in terms of issues that affect these, heart conditions, certainly, that affect the Black community in bigger numbers, percentage-wise, is this a call for better wellness to be prepared in general?
I think that is almost a dangerous slippery slope because it puts the onus on betterment and essentially protecting yourselves from outside factors on the people who are suffering from it essentially themselves. But where we see, yes, African Americans very much so are more susceptible to certain pre-existing conditions, African Americans are more susceptible to certain pre-existing conditions. We see that with diabetes, we see that with hypertension, obesity, but in researching or even looking at those varying factors, that also plays into our healthcare disparities. That also plays into other disparities, like we said, food insecurities. African Americans are more likely to live in a food desert. Only 8% of African Americans live in a geographical area that contains a supermarket. That impacts the quality of food that you're going to have access to if the majority of your groceries come from a local convenience store as opposed to something that has healthy options like fruits and vegetables. That's going to play into how you see the prevalence of obesity in communities. That's going to play in how we see diabetes and hypertension in communities. So yes, are African Americans more susceptible to these conditions? Absolutely. Does that make them more vulnerable to the coronavirus? Absolutely. But what are the underlying factors that make even them more susceptible to those conditions? And when we get to the root cause is racism within our healthcare system, racial inequality, and the main issue is that we have long-standing institutional disparities that make access to healthcare, access to better income, access to just essentially the American dream a lot less attainable for African Americans.
And what, and I want to just sort of clarify that I was talking about it as sort of societal betterment, not just being upon the Black community, because we all suffer, obviously, when there is this disparity. Our hospitals are overwhelmed. Our healthcare system is overwhelmed when it need not be. So I want to ask too. I want to ask as well about patient bias, right? I mean, let's talk about, we spent a lot of time talking about why so many African Americans are disproportionately affected. What about when somebody gets to the hospital, when somebody's presenting? Let's talk a little bit about the racial bias in medicine, in patient treatment, and explain how that manifests.
Absolutely. So what we're seeing, and we even see it in the headlines that appear throughout the outbreak currently, is that oftentimes African Americans are seeking treatment, even though we're more likely to be, even though we're more likely to be distrustful of the healthcare system, we're less likely to have a primary care physician, we're less likely to seek treatment in the event that we have certain symptoms. African Americans are seeking treatment. And what are we seeing? They're being denied. We just saw most recently a young woman in Manhattan who sought a test 4 times and was turned away and recently died of COVID-19. It's not just that African Americans have certain underlying conditions or that there's healthcare disparities. We know that. But there's also then implicit bias within our healthcare system, among our healthcare professionals, and among those who are supposed to be tasked with providing that quality care. We see that in terms of our disparities in maternal health for Black women. Black women are 2.5 more times likely to die in childbirth than their white counterparts. That's because Black people simply aren't being believed. We go and we express our symptoms, we say that we are experiencing X, Y, and Z, and because we are more prone to those underlying conditions, we're more likely to be written off as those underlying conditions. So when we talk about those implicit bias, that exacerbates the issue where we're seeing African Americans are trying to seek that treatment and being turned away.
Yeah, it's exacerbated situations all over. I mean, we're looking at a historically tragic pandemic. And so you see the bad news, and then there's bad news within the bad news. Kenya Evelyn writes for The Guardian. You can see her reporting there. Thank you for sharing this perspective that's so important and I think is being talked about now in ways that is actually gratifying because it hadn't been. And now I think you see people talking about it, probably because of your work as well, Kenya. Thanks for being on the Young Turks.
Thanks for having me.
On the go? Don't worry, we got you covered. You can still listen to TYT at our new podcast network. Find us on Apple Podcasts, the Google Play Store, or at tyt.com/podcast.